I would say every physician that has a GPT account has probably played around with ChatGPT acting as a doctor or a patient. It's pretty good.
Welcome back, ladies and gentlemen, to another fabulous episode of the Healthcare Trailblazers podcast. I'm excited to be sitting today with Graham Walker. Graham is the Assistant Physician-in-Chief at the Permanente Group. As many of you may recall, we had Robbie Pearl a couple months back. The Permanente Group, obviously massive group, about 10 million patients, if I recall correctly, and one of the most prominent healthcare organizations in the country. So, Graham, thank you so much for joining with us today.
Thanks for having me, Mendel. It's great to talk to you.
So you're an ER doc, right?
Yeah.
And so tell us kind of why you decided to get into medicine and why ER.
Yeah, that's a great question. My family is in healthcare. My dad is a first generation physician. I guess that makes me the second generation. And my mom was an ER nurse and a dental hygienist. So I guess healthcare is somewhat in my blood. And I think I saw what my dad did, and I saw what my mom did, and I guess just appreciated that their jobs were certainly challenging, but that they both had a bunch of knowledge that was really helpful raising children, I'm sure, and then also felt like they were able to make a difference and try to help people. And so medicine was always kind of on my short list of things to do after college. And then I chose emergency medicine because I really liked the challenges of trying to very rapidly gain rapport with people, having to kind of understand a little bit of everything of medicine. And, I think at the time, I really liked the idea of, being the physician on the airplane who knows what to do. If somebody says, "Is there a doctor on board?" It's like, oh, that's literally, what I was born to do, or trained to do, I should say. So I think those were all the reasons I did medicine and emergency medicine specifically. I did residency in New York City from 2008 to 2011. So depending on your math, I've been an ER doctor for somewhere between 12 and 15 years, and gone through COVID. So emergency medicine is a bit different now than when I was in medical school 20 plus years ago at this point. But yeah.
Yeah. Thank God I've only had one interaction with the ER. I tried this new diet a couple months back. So I only ate meat and I ate once a day. So I was doing like a 20 and I was only, so I guess I didn't compensate enough with increased water. Also, fun fact, kosher meat is salted to take all the blood out. And so it's actually like even more than regular meat. It has even more.
Interesting. Yeah.
So the diet promptly gave me a kidney stone. So I ended up in the ER. The guy pumped me up on fentanyl. After like an hour of sitting in the room, guy came in, pumped me up on fentanyl, and that was it. It was good to go. So it was a good time. But that's really great. So let's, there's a clear big passion of yours. You put out fantastic content on LinkedIn. Highly recommend everybody to check out Graham Walker on LinkedIn. And a lot of the focus is around AI. And so obviously big buzzword these days. Let's jump into it. What is exciting to you about AI? What are your general opinions? And we'll take it from there.
I would say, and I think this is the view of most of the physicians that I kind of talk to and network in the space of AI. Say we are cautiously optimistic, with AI generally, and I think physicians and everybody in healthcare sees all of the problems and all of the challenges every single day in healthcare, and we see some slice of them that AI could help us with. Mm-hmm. Do I think that AI tomorrow, or honestly even in 5 years, is going to either be replacing doctors or suturing up a laceration or talking directly with the patient? I'm not exactly sure. I don't think so. But we see lots of pieces of our own work, whether it's honestly in nursing or social work or emergency medicine or anesthesia, whatever it is, we see some portion of it that we could either get help with and do a better job ourselves, or we see areas where we would love to be able to have more time to help explain things or spend more time with patients and we simply just don't have enough minutes in the hour to do so. And so we see an area where if an AI tool was trained properly, was found to be unbiased, with lots of caveats,
Mm-hmm.
we think a tool could be extremely helpful. And I guess the other piece is I don't see many other technologies or options out there that are potential solutions here, right? People are getting older, they're getting sicker, medicine is more complex, medicine is more expensive. There's all of these competing factors, and I'm not seeing other options outside of a technology or an AI solution, honestly, right now.
Yeah, yeah, it's funny. I feel like those things actually go together. Healthcare is obviously historically very technologically stagnant and behind many other industries.
Yeah.
And it's interesting. I think that because it is so slow to to advance with general technology, there's like so much almost like crust that's built up that that artificial intelligence can really come through and kind of wash away. So what would be kind of the number one thing that or task or process that you would like to see artificial intelligence take off your plate, and what would be the thing that you would never want to see artificial intelligence take off your plate?
Oh, that's a great question. Um, we talk, I think most of us feel like patient facing AI is more risky, right? Because especially the generative stuff, right? A machine learning model is probably, a neural network is probably safer in some ways, but generative tools, especially that were, a little over 1 year into ChatGPT, right? It came out like around this time last year. It's crazy. It's only been a year. The
Yeah.
generative tools, the hallucinations, the fact that the Sydney, that Bing chat thing was hallucinating and telling people they love the user, right? I think there's enough risk there that we feel like the generative stuff, patient facing is risky. But the thing that I would love to be able to bring to my patients is just an ability to provide the same level of quality of responses that a physician provides, but just that like a user, a patient could interact with, right? So let's take your kidney stone example. I diagnose a ton of kidney stones in San Francisco. I don't know why, maybe it's the water, but um, I would love to have 20 minutes to just sit down and go through every single thing that I know about kidney stones to help the patient going forward. I'd love to spend a full 10 minutes explaining what the follow-up process is with urology. I'd love to spend, another 10 minutes explaining what's lithotripsy, what's stenting, why would we choose one or the other. I'd love to go through all the options of why I chose this medicine to prescribe and not that one. To go through the diet, like I would love to have a sit down for a half hour. Just, hey, what questions do you have? And also, oh, Mendel, I'm discharging you, but if you have more questions, go ahead and shoot me an email any time of day or night,
Right.
and I will promptly respond to those questions. So I would love to be able to take doctor knowledge because patients have all these questions that I wish I had time to answer, but I don't.
Mm-hmm.
And I'd love to be able to offer that to patients. So that's something I would love to do. Again, it's certainly more risky because it's kind of patient facing, but I think it could be done safely with technology and some kind of guardrails. One thing that I think AI should never do. That's another great question. Um, I think probably anything that is a significant life changing or critical decision, and there's so many of those. I know that's a vague answer, but like you know you could imagine even an AI model, like a machine learning model, could probably predict if somebody has appendicitis, right? Or it could even it could take the patient's history and read the CAT scan and say you have a 99% chance that this is appendicitis. We're going to take you to the operating room. I think that decision of we're going to cut you open
Yeah.
should always have a human in the loop, and other risky things, right? Like I want to start chemo on you, right? There's numerous things where it's like the physician absolutely needs to be in the loop. Some human needs to own and be responsible for this life-altering decision about XYZ, right? Even if the AI is helping, be the co-pilot, help in that decision-making process, ultimately, I think a human's got to be the one that says, yeah, I agree with all of this. I agree this is appendicitis. We should put you through the risks of anesthesia, cutting you open, taking out your appendix.
For the record, I completely agree with you. I would even go further, and the way I like to split it down is doing like brain and heart. I think that the heart belongs with the humans, and the brain,
Sure.
we can find value in AI 100%. But I don't like when, at least as of now, when AI kind of oversteps that line. But from a
Yeah.
physician side, Sam Altman loves to talk about their eventual goal with AGI and just general intelligence, this thing that kind of knows everything. And when you talk about unbiased, the big fear with AI is that it's biased, right? And it has biases, but us humans also definitely have biases. And I'm sure that there's a lot of physicians with egos that maybe push patients in one direction or another because of perhaps their own biases. And so at what point would you say that perhaps, do you think that would always be true? Or do you think that AI can possibly end up at a place where it'll actually be able to provide a more comprehensive and unbiased approach to even the physician, maybe not even necessarily to the patient?
Sure.
Yeah.
That's another good question. I don't know. Right now, all of AI is based on pre-existing data, right? Um, and so if you argue that, and I think this is true, if you argue that all of data has some bias, right? And if you certainly the medical community has plenty of bias within it, and even if you're training a model on a huge data set, the model is going to learn from those biases, um, you know, and so I struggle with this a lot because I think you're absolutely right. Humans are absolutely biased. Will an AI tool based on humans be less biased?
Right, right,
I
right,
don't
right,
know. I don't
right,
know.
right. Yeah, no, it's a good thought. I guess my understanding is that should AI reach that stage of like AGI, it would go beyond the knowledge that it's built on. So it would go from a thing that's responding to trillions of data points to a thing that actually forms its own intelligence and can actually understand that
Sure.
it should not be biased by that thing, right? Because it's very clear right now that the various models have biases in different directions, right? There was a lot of examples coming out earlier about GPT that you'd ask it to make fun of Biden and it would say no, and it would make fun of Trump or things like
Yeah.
that. And then obviously you see like with Grok, it's got like this great sense of humor versus what I mean. So there's definitely it's obvious that right now it's like that. But yeah, I think the presumption is, at least my understanding is that should it reach there, it would be able to get beyond the human bias. But yeah, I think definitely everyone would agree that that's quite a ways away. I was listening to Sam's episode on Rogan last night. I was driving a couple hours and had some time, and yeah, very interesting conversation about it. But yeah, it's really cool. So, are you using anything right now on a clinical level that is helping with some of your workflows?
Yeah, we are using this AI scribe tool or ambient listening tool. It's called Nabla, and our Permanente Medical Group organization made a deal to offer this to all of our Northern California physicians, and essentially, Nabla takes audio, like records audio, just like you and I are recording right now, transcribes it into English, which probably this is going to be transcribed as well by an AI tool. And then based on its understanding of medicine, the practice of medicine, and some prompt engineering about what what the template or what the structure of a medical note should look like and the order, it generates a note based on whatever you're talking about with the patient. Um, we have a pretty strong usage of Nabla so far in the medical group, and for some people, especially people that I think have had challenges with either typing or dictation or, getting everything in the note that they want in the note in a timely fashion, it's helped them a lot, like saved them hours every single day, which you can imagine hours a day
Big deal.
times lots of physicians. That's a lot of money.
And it's not just hours, it's hours of tedious burnout work.
Absolutely.
Yeah.
Yeah.
Yeah. Wow. Going back to kind of patients for a second, we mentioned this before we started recording, but historically doctors have hated, I think, the Dr. Google concept where like patients are Googling their symptoms and every single time they cough, they have cancer. And, and then like, well, Google said, and you're like, I'm your doctor, I'm giving you advice. Why, in your words, would kind of an AI conversation with a patient be different than that for the patient?
I would say every physician that has a GPT account has probably played around with ChatGPT acting as a doctor or a patient. It's pretty good. I mean, is it perfect? No way. Is it at a physician? The same expectation you would have of a physician? No, but it's pretty good already. Um, and I find that to be a more useful validation or measurement than a lot of the other papers look at, like, can this large language model pass like the medical board exam,
Mm-hmm.
which is all multiple choice, right? And that's I find all of those papers kind of silly because medicine is not a medical choice exam. Patients don't come in and say, well, I could have one of these 5 things. What do you think it could be? They just come in with symptoms and signs. And so I think there will be a time when a large language model is offered to patients that's vetted by some authority, whether it's a medical group or a hospital system or a government or a regulator, and say, yeah, we think this is appropriate as a first line tool, or this is approved for these indications, right? Like basic questions about self-care at home or basic first aid, right? You can imagine you probably wouldn't want to start out with like people with chest pain or abdominal pain, because those are high risk chief complaints. But you could imagine somebody has a question about a scrape, somebody has a question about an ankle sprain, somebody has a question about poison ivy. I think there will be large language model tools out there that will replace the Dr. Google and will safely and effectively answer some basic questions. And I think there will be kind of incremental gains from there, with lots of guardrails that say, oh, well, you have an ankle sprain, but you can't walk on the ankle. Nope, you should not use this tool because you actually have a much higher risk that you have a broken ankle, and that should not be treated the same way as an ankle sprain. So yeah. I think there will be incremental gains, but we need the ability to evaluate these models with kind of a standardized rubric or a framework, and we need someone to approve them or come up with some guidance about medical legal risk and responsibility and all that, because it's going to be a challenge going forward, and
Yeah.
we need to do it right, or people being either doctors or patients won't trust these things. If the first one's a total flop, people won't trust them, and it'll set the whole industry back 5 years at least, I think.
Yeah, 100%. Yeah, I think there's a really good opportunity right now to prove that this isn't what the fear is. And if the tiniest bit of confirmation bias were to come in, it would shatter the whole thing. So 100% there. Graham, one of the things that's been most impressive to me about watching you and your content on LinkedIn has been the fact that, you're with the Permanente Group, massive organization, and yet you seem to have this super agile energy about you. You're adopting things already, whereas I think a lot of the other large organizations are like holed up in the boardrooms, like, what do we do about the AI? What do we do about the AI? And right now, let's shut it down. Let's figure it out. Talk to me a little bit about the culture there and how that allows you to just like point to different directions and move. And I think it's incredible.
Yeah, thanks. I will say that I'm certainly the at the I would say the cutting edge, the bleeding edge of the medical group, trying to understand this technology to figure out how we can use it again safely, accurately, appropriately, and so that's part of my role that uh, I think that I should be kind of pushing people forward and kind of in an innovation experimental um, role where I'm trying to understand this technology and see how physicians could apply it, and how the organization could scale it and use it. Um, I think what drew me to the Permanente Medical Group is that and Kaiser Permanente generally is that we have I think more aligned incentives than a lot of other places in American medicine.
Hmm.
Our goal is to keep people healthy and to keep people out of the ER and out of the hospital as much as possible. Um, and so our incentives try to help us do that in a safe and good way, just because of the way that our insurance kind of product works. And then I think our medical group has a renewed interest and a renewed awareness of uh, the same recognition I talked about earlier. We have significant challenges in medicine. They're not just because of COVID. A lot of them happen during COVID, but they're not just because of COVID. And we have to find new ways of providing care. Um, there are certainly things that are inefficient about the way that care is delivered in the United States. I think a lot of them have to do with laws and regulations that definitely need a refresh from Congress and from state legislatures, that would allow everything in healthcare to safely and better adapt and use technology, and including AI. But I think there's a recognition that COVID changed all of medicine permanently, whether we like it or not. People have an expectation about video, video based telemedicine care. People have an expectation about being able to get a quick response back from a physician, and that's been a challenge, not just for our organization, for everybody.
Yeah.
Nobody has a right answer yet
Yeah.
in healthcare. But we've got to try something, because we've got patients that we need to take care of.
Right. Yeah, and yeah, I think it's a relatively unique. It's not just a realization, but mode of operating that you guys have that seems to be unique with the organizations kind of your size. So I guess kudos to you.
Well, Mendel, I think also the fact that we're in kind of the Bay Area, Silicon Valley, we're aware that there's big tech coming for us, or the big tech thinks they can do it better than us, and
Right.
so I think we have to put our money where our mouth is, and big tech has the money, we have the experience, and we need to be able to show people that we are able to innovate and change and deliver a lot of the things that big tech is promising, and that so far, no shade, big tech, but so far, big tech has failed numerous times on, but spent a lot of money in the process.
Okay, so let's dig in there a little bit, if you don't mind. So there's Amazon jumping in, obviously in a big way with One Medical,
Yeah.
right? There's, I mean, CVS is kind of but you've got Walmart with Walmart Health. You've got Walmart Health. You've got more recently, mind-bogglingly, Costco, with like $27, PCP visits or whatever it was, $17. Um, what are your thoughts in general on kind of those big players coming into the market? What are maybe any successes that you've seen, or advantages, and what are kind of some failures that you've seen or disadvantages?
In some ways I might, and this is totally off the cuff, but in some ways I might have more confidence in Costco or Walmart, because they they deal with the general public. They deal with a wide swath of the population, and specifically a wide swath of the population that I would imagine has varying ranges of healthiness or morbidity,
Right.
or disease burden,
Right.
as we might say in medicine, compared to big tech. Sure, everybody uses Amazon, but does everybody use One Medical? No, One Medical tends to attract and include. I don't have the data, but I'm sure this is true. Generally, much healthier people than the average American.
Yeah.
Right.
Yeah.
So
It's
I
going to be
think
the
I would
younger
imagine.
demographic, which is going to be Yeah.
Yeah, yeah. I mean, if you just looked at age alone,
Hmm.
ignore everything else, age predicts disease, right? As you get older, you accrue and you Pokemon capture more diseases over your lifetime, or you die. Those are the two
Yeah.
options. Very few things in medicine are cured,
Yeah.
right? In the whole medical system, I'll go off on a tangent. The whole medical system is based on this concept of curing disease, right? You put people in a hospital, give them some antibiotics, or take out their appendix, and they were cured. And that's still what the model of medical training is based on, this idea of cure. But everything now is managed. It's all dilemma. It's not cured. So I think the fact that that Walmart and Costco probably manage and interact with patients of a wide age demographic probably gives them a little bit better perspective on the things they will need to do to successfully grow. One Medical, I wrote an Amazon post about this, but One Medical can absolutely continue to grow with young, healthy 20 and 30-year-olds. But I would have serious concerns about One Medical making a dent in trying to help the 85-year-old with 20 medical problems.
Yeah.
Now, maybe that's not their goal, and that's fine. But I don't, healthcare doesn't have that luxury of saying, no, we're just going to take care of the 20 and 30-year-olds. My ethical and my responsibility is to help anybody that needs my help, not select out for a narrow slice of people that are going to be easy to take care of, if that makes sense.
Yeah, I agree with you 100%. We've had Walmart Health on the podcast, and I am most excited about that because exactly what you said. They are in the hearts of those demographic areas.
Yeah.
And the person that's shopping at Walmart, their motto is, save money, live better. Like the people that are shopping at Walmart are looking for discounted food and they have healthy options. And so this, I think they're nowhere near because it's two separate organizations. But to me,
Yeah.
what would be so interesting is some sort of fusion between the two, where if you are trying to get me on some sort of preventive, diet or whatever, I should actually be able to just like open my Walmart app and have like a suggested cart with like all the stuff in there that
Yeah,
knows
sure.
maybe my, you know what I mean? So and they're nowhere near that. But I think that conceptually would be so cool, the fusion of it. I think Costco probably, although I agree with you, probably less so. First of all, there's a cost for membership, which is obviously a barrier for low income people. And then also just, yeah, you are saving money by buying in bulk, but you also have to have the money to buy in bulk. And a lot of people
Yeah,
are unfortunately living day to day. So I think that a little bit less of it. But
absolutely.
the only argument I would maybe make in the contrary for Amazon is that although you're absolutely correct today, it is necessarily a short term problem. And so necessarily in 20 years won't be an issue because the 40-year-olds of today that would be comfortable are then
Yep.
going to be the 60-year-olds then, right? And so, could be maybe they're thinking, and I would imagine they think in 50-year, kind of timelines.
Horizon.
So that's the
Yeah,
only thing I
yeah.
would say. But as far as today, I think you're absolutely spot on. Yeah.
Yeah, you're absolutely right. And part of the barrier is certainly technology, right? And as the decades move on, a larger percentage of your population is both tech enabled and accepting, or even prefers a technology first approach to care. I think that's one of the challenges with the place we're in right now is we have patients with wildly different preferences
Yeah.
in terms of how they want to interact with the healthcare system.
Yeah.
Older patients typically are going to want to go in and see the doctor.
Not just the
For
doctor, their doctor.
correct, that's a great distinction. They want to see their doctor and only their doctor because they know their doctor and their
Right.
doctor knows them. And then you got a slightly younger group that still wants to see a doctor in person, and then you got a slightly younger group that would prefer to email or text first, or do a video visit, and then you've got the slightly younger group that's like, why am I talking to a human at all? Why don't I just text? Why don't I just text with someone or text with a chat bot,
Right.
or like I'll use Google and I'll figure it out myself.
Right. 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 Right.
Yeah.
Right. Yeah. So this actually segues into something that I've been talking about recently. I'd love to get your thoughts on. One of the biggest inhibitors of innovation in healthcare is the regulation around it, right?
Sure.
And take HIPAA and data privacy are some of the biggest things. And my opinion is that those are the younger age, the younger demographic would absolutely trade their
Hmm.
data for more convenient healthcare. I think that the entire idea of data privacy around healthcare is kind of I don't know, baby boomers, whatever you want to, whichever generation you kind of want to blame it on. I think that it's an excuse that's used for the larger companies that now own all the data to not want anything to change, because then the market opens up. But in reality, I think if you ask the average 30-year-old right now, do you actually care if the Russians know that you have like early onset diabetes? Versus, all right, so we'll give them that information, but then like you absolutely like the most convenient care and your data is accessible by all your docs and you own your EHR, like all that
Yeah.
kind of stuff. I think every single young person would trade that. Do you agree with that?
I've never thought of that, but I love that concept, and I kind of do. I think there are some there are some conditions that are stigmatized or taboo for sure. That maybe there's carve outs for those, but I fully agree that many I would say young people, but I'm 43, and I think I'm an elder millennial. Um, Many people would be perfectly fine um, being able to text with their physician or having their physician text them
Yes.
than have to log into a portal
Yes.
because of HIPAA requirements. Now,
Yes.
I would argue that there's probably some middle ground where you could you could update HIPAA, which, my God, it's from 1996, right? The internet was barely
A thing.
existing. I think Amazon came out in 94 or 95.
Yeah.
Um, you could update HIPAA and find a happy medium where either it's really easy to consent to text messaging, or it's really easy to consent to just email me my medical problems, or email, not have to use a portal. um, and that consent can be retracted, right? Like, the technology exists to make it really easy to toggle on and off consent, and to
Yep.
say, to send a message and have the message just go to the patient's preferred means of communication:
Yep.
text, email, phone, whatever.
Mm-hmm.
But I totally agree with you. The laws absolutely need some updating. Um, but I also agree with you. I think some people, especially younger, healthy people who also tend to not have medical problems, would be fine with, hey, can you text me a picture of my ankle x ray?
Yeah.
I want to post it on Instagram or something.
Yeah. I'm just saying that, yeah, and that's an interesting thing to consider. I still think, I mean, you definitely have young people with significant health issues, and I
Oh, of course.
still think
Yeah.
they would.
Yeah.
Like, if we could play out an experiment, I think that if you would come up with a form that basically would say, I accept to just, like, I don't care about HIPAA for me. Like, I don't care, and I could sign off, and then I could do whatever I want. I could communicate, and
Yeah.
your communication thing is spot on, because that is probably the lowest hanging fruit issue. I think that the amount of people that would sign that would be tremendous. But what I think would be more interesting is where the pushback for that would come from. I think would be very telling, right?
Yeah.
Because I don't think it would necessarily come from the people that you would expect. I think it would come from a lot of the people that essentially own the data right now. But that's
I could see that.
there. Yeah. Yeah.
And Mendel, I mean, I think you can do that today, but there does seem to be some barrier to that happening. Whether it's lawyers saying to health systems, "My God, don't do that." But there are doctors that text with their patients because they've gotten consent to do so. But
Yeah, but correct me if I'm wrong,
I
but
think
I'm
it's
pretty sure you would have to have a concierge model where you're paying cash. Like, I don't think you would really be able to do a lot of that if you're in the traditional system and you're billing traditional payers.
yeah. I don't know. I don't know. I mean, there's clearly some reason
Yeah.
no one is doing this,
Yeah.
I just don't know if it's a theoretical medical legal risk, or a privacy risk, or people just don't want to deal with even the concept of a complaint from the Department of Health and Human Services in the U.S. about privacy, and so it's just easier to not even offer it. But yeah, I agree.
Yeah. Interesting. Okay. What would your advice be to the government on how to best regulate, specifically, CMS or whatever? Like, what would your advice be to the government on how to best regulate AI while not getting in the way of innovation?
Man, that is, yeah. I don't
Just off
think
the
the
cuff.
FDA. I don't think the FDA has an easy job. I've thought about this like a lot. I was a social policy major in undergrad, so I tend to think about things in like, okay, if you say this, what are the unintended consequences of that, right? It's one of those things where it's like you know it when you see it, um, but it's hard. It's really hard to put down on paper. I think one of the better ways would be to break down AI based a little bit on based on the kind of type of AI, and then have some validated models or evaluation tools that are like um, approved, right? Like you need to do at least this well on this evaluation tool, and you can't have failed on any of these. I mean, it's AI, right? You can't have failed on any of these 1,000 responses if we're talking about like a large language model or something. Um, I think there's another option where like you give, the FDA or somebody could create a base model that is approved or something like that, and offer that to everybody in the U.S. to use and then build upon. Because I agree. I think the regulation piece is extremely challenging, and I think the FDA is going to have a really hard time keeping up with all of the AI applications that will be here very soon. And that they have said, "Yep, we want to regulate this. We want to be in charge of this." I think they kind of almost like um, a running regulatory review of like what the technology is doing, because I think even with their current framework, I think the technology is going to challenge that framework
For sure.
significantly.
For
And
sure.
the language in it, that's the challenge with language, is how do you interpret it?
Yeah.
It's like I think some of the regulations ask like, well, does this tool suggest a diagnosis, or does it just prompt the user to consider a diagnosis, right?
Mm.
That is such a tiny,
Right.
that's splitting
Right.
hairs to figure out.
Hmm. Yeah. I, what would be the worst thing? Like if you and I'm asking you because you're boots on the ground, you are a doctor that is heavily interested in using artificial intelligence, you see the value of it, but you also understand the risks. And so that's why
Yeah.
I think it's very important for the government to hear from somebody like you. What
Yeah.
would be the worst way for the government to go about regulation?
Oh man. I mean, obviously, just a flat out no,
Yeah.
but
Shut it
I think
down.
a more nuanced bad decision would be, um, a really bad decision would be just to not know, but hey, we're just going to pause this for a couple of years.
Hmm.
Um, I just have big concerns about. Um, I mean, I see both sides of it. I have big concerns about some kid in their garage putting a little wrapper around GPT-4 and saying, "Hey, use this for your medical care,"
Right.
because it'd be right, probably right 80% of the time,
Right.
or 90% of the time, but that's not acceptable.
Right.
But I would also see big risks in not allowing health systems and kind of established entities to try things and to
Yeah.
build and
Yeah.
to it's kind of like why I one of the things I like that YouTube has done is YouTube. If you're watching a YouTube channel from from a medical provider, they have a little, and they're talking about medicine and
Right.
their stuff. They have a little tag that they add to every video that
Yeah.
says
Verified.
this content is from a U.S. licensed medical provider.
Yeah.
Um, because I think that provides I think some level of informing the user, um, and letting the user, and not being super paternalistic with the user or the patient, um, and to understand that like this person, um, I would hope would provide accurate information. It's certainly not been true with COVID all the time, but like, provides some level it provides some low bar of trust.
Yeah.
Because otherwise, I could absolutely see the FDA or other regulators, completely shutting down AI
Innovation.
tools.
Yeah, yeah,
Yeah,
yeah, yeah.
Judy Faulkner at Epic, said as much at their conference recently, that they were concerned that the FDA regulations were suggesting that everything is clinical decision support, and that the
Right.
FDA wants to regulate all of that. Now, whether that was her just trying to create more barriers around competitors to Epic,
Right.
or if it was a true concern, I don't know.
Yeah.
But that's the challenge. If everything that pops up on the EHR screen that says this patient has a low temperature, you might want to recheck their temperature and make sure they're not hypothermic.
Right.
If that is decision support that the FDA wants to regulate, the FDA is in for a world of hurt, because if they did that today, they would have hundreds of millions of things that they are now responsible to regulate.
Yeah. Right. I think that's a really pragmatic and smart approach. It basically just focuses on transparency, and what you're essentially saying is that if you can just double down on giving people more information about where this information is coming from, and just not allow people to misrepresent themselves or misrepresent the tool, then that would go a long way towards consumer, understanding of what they're using. I think that's a very smart approach. I want to give more thought to that.
Yeah, it's a little bit like the Apple iOS guidelines model, where if you're going to put in, I need to look at them because they're always changing, but if you're going to put in content about medicine or prescribing or diagnosing, I think Apple says like you have to be affiliated with a health system or affiliated with some official thing, or an established. I mean, how do you define established? I don't know, but you have to have some affiliation with a legit thing, so that you don't have just some kid making a epinephrine dosing calculator in their garage, and they're potentially causing harm to people because they're downloading it or something.
Right. Fascinating. Wow. Well, we could go on for hours, but unfortunately, we're coming up on time. Dr. Walker, thank you so much for spending time with us today. I wish you tremendous continued luck in your fast-moving endeavors over at the Permanente Group. And once again, everybody, look at you on LinkedIn, Graham Walker. Anywhere else that people should find you?
No, that's the main place where I'm putting most of my content these days. I left Twitter about a year ago, and I don't miss it one day.
So LinkedIn it is. Graham Walker, thank you so much for joining us today.
Thanks, Mendel.